Oh, hello, Emily. Welcome everybody to the April 30th Gravity Public Terminology meeting. We are in end-to-end review on our three domains: child maltreatment, mistreatment of non-elder vulnerable adults, and legal needs. We will begin ever so shortly at about 3 minutes after the top of the hour, and I might uncharacteristically step away to get my tea, that I put the tea water on. But again, I'm Sarah. I have the honor of being the director of terminology. And if you want to put in your name and where you hail from in the chat, it helps us for attendance. And I will start. And I am going to quickly turn off my camera and just let folks put in their names and go get my tea and come right back.
You made it back. You're on mute.
Ashley's like, you're back, but nobody can hear you. I did. I ran to get my tea, and I thank you for your patience, everybody. Welcome. We're going to start in about 3 minutes right now, actually. It is now 3 minutes after the top of the hour. And we will get started on the business of the day. Oh, and Rob, I'm glad you're here because we have a you've yet to see the solution that we created after your observations a month ago. So we can report them back on them now. Welcome to the Gravity Terminology Public Call. Again, we're an end-to-end review. We're going to talk more about what that means in the next couple minutes in our hour, and we're glad you're all here. Next slide. We appreciate your presence. We are usually a small but focused group of folks, but we do start muted, and you can always come off mute and raise a hand or enter the conversation. At this state, not much of the content is new, right? Because we're just kind of refining. It's important to note that all calls are recorded and all recordings are available on the Gravity Confluence after the call. And we encourage everyone to participate, right? So there's a lot of materials on the Confluence that we've gathered to date. The slides have a lot of content. We just want to make sure that everyone weighs in as we head toward the vote at the end of May. Next slide. We are an accredited, because we work with an HL7, we're required to follow American National Standards Institute antitrust practices. And so we have to comply to them fully as part of our approved method of developing standards. And so we just are very careful to ensure that individuals who are speaking or communicating or writing can refrain from discussion on prices and services and production. And we actually have never had a conversation based on prices or production or allocation of markets yet. Doesn't really fit into our domain work, but should you just know that we are very stringent in applying these guidelines, and it's not just direct violations, but anything that might be construed as somebody by anyone as a violation. We just try to maintain our focus on the work at hand given our ANSI accreditation. Next slide. We have some announcements today, and then we're going to go through our 3 domains and then close with domain enhancements and community homework and next steps. So again, the homework is a little bit more formal than usual because of the N10 review. Next slide. Next slide. So there's one new thing. Actually, there's 2 new things on here. So we in terminology are one of the 3 work streams of Gravity. The other one is our technical work stream, and then the implementation work stream. So tech is working through the ballots on their Standards for Trial Use 3.0. And that's the focus of our meetings every other Wednesday from 1 to 2 Eastern Standard Time. We are having a special session on the 13th of May, focused on, which is in like a little over 2 weeks. It's focused on revisions to the conceptual model. One of the tickets in the implementation guide ballot focused on needing to apply observations for opportunities to improve the model that have been noted for a very long time. So because it's part of the ballots that we're reconciling, we are taking an effort to update the conceptual model over the course of the last months and years, really. We had a co-design effort toward the same end in 2024. So there's a whole page on the Confluence on background. We're not going to go into it here, but you can read a brief we wrote on the model and its opportunities and possible improvements. You can see our past model and our current model, current proposed models on the Confluence there as well. And we invite everyone to attend the May 13th call, because instead of having many different one-off conversations in our different work streams, we're all going to try to focus on that 513 meeting to review the model and get feedback. We want as much feedback as possible. You're still welcome to follow the link, and we developed a standardized spreadsheet for commenting on the model categories, but please do come to the call if you can. And just noted, it's important to note that the version of the model right now is just the components of it. It's not a visual representation of the model and the interrelationship of those parts. We, as data standard people, just wanted to get the basic components ready right first. So when you comment on it, just know that to be the case. And so please navigate to the Confluence, look at the materials there, and come to the tech meeting on the 13th where we'll talk more about it. Any questions there? Okay, the Confluence page has so much information. We hope it's enough for you. And if it's not, just write us, because we want to help everybody understand. So the next work stream is implementation work stream. Just make sure that I'm not missing anything in chat. No, it's just Sarah. Amazing, Sarah, putting links in. Our implementation work stream meets every other month. We are trying to respond to implementer questions on like how to use our standards, and one of those was on methods for identifying positive findings from screening instruments. So we're going to be talking through some of the ways we do that in terminology and tech on that May 28th call from 2 to 3 Eastern Standard Time. And we invite anyone who is interested in that to come and join. Any questions on that? Okay, next slide.
Sarah,
Yes. Hi, Lucy.
hello, everybody. I'm wondering when the next implementation meeting will feature a new case study from somewhere about how things are going.
You made a case study on implementation?
What somebody used to call the affinity group type meeting where.
Oh yeah, that's it. Yeah, so that's what we're doing. So Lucy, we had a survey. So what I hear you saying is it'd be great to get feedback on how implementation is going as part of the affinity meeting as well, as opposed to just delivering education. Is that what
Right. Yes.
Okay. So we had a survey toward that end before we'd sent it out all over the ecosystem. And what I commit to doing is providing brief updates on what we know at the beginning, since I can do that at the affinity meeting on the 28th. But one of the things we heard very loud and clear is that feedback on implementation happens best in longitudinal relationships with specific stakeholders. We already knew that kind of. And so one of the things we're doing in 2026 is actually leaning in and developing, identifying relationships with both members and non-members where we can like sit with health systems as they implement our standards and get an understanding of how they're doing. And we don't have anyone documenting that from an academic standpoint, which would be very smart. Maybe we can try and do that. But so we promise to bring up whatever we're hearing and finding back up into the affinity meeting. But we have a new take, which is really trying to develop, lean into spaces where people are talking about implementation and develop our own longitudinal relationships with them, building off of the New York model. I hope that makes sense. Lucy, does that make sense?
It's a little bit of a change of direction and a different or a new element in Gravity's scope of work to be available one-on-one
Well,
to
it's not,
help
yeah.
implement. So I hope they're paying. Let's just say that.
Well, the members already are, right? Members already support this work through, so
Okay,
that, yeah. And then we do have pay technical assistance relationships with like New York State, and that's been really beneficial to improving our standards. But certainly, thank you.
okay,
Regardless, these part of the reason why the evolution, again, sorry, we're talking a lot about this, is we're in a different phase, Lucy, than we were 4 years ago, right? Our
right.
standards are everywhere. They're getting written into state regulation. We don't follow and know wherever they go. I mean, like it's so we are trying to evolve to meet that reality where we're no longer piloting. We're way beyond that, right? So we actually have to, we're trying to shift how we get feedback to make sure our standards are working. And you are finger on the pulse, recognizing that as well, per usual.
I'm always back at each one, teach one.
I know, I
So,
know.
so the case study approach has always been of interest. If
Mhm.
that isn't on the agenda right now, maybe it will come back at some point when there's somebody who wants to talk about it.
Love
Okay,
it. Okay,
over
carry
and
on.
out. Thanks.
Thank you so much. Okay. Okay, so we were just talking about implementation, and what I'm just going to reiterate the highest level of what we say. So every year, the implementation affinity meeting and the implementation work stream thinks about how to get the best information from implementers. For many years, intentional pilots because there wasn't were the with the primary method because we didn't have a lot of implementation. In 2026, implementation of gravity standards is everywhere, right? And we recognize that the public meetings that we'd had in 2025 were not the best way for us to learn, even though they were a good way for the community to learn. We weren't learning about enhancements to the standards the way that we needed to. And members, and we heard a desire for specific education to return to those meetings. And so we're trying for 2026, we're focusing on that. And maybe we'll publish our findings as case studies, Lucy, from those longitudinal relationships. Go team. Whew. Next slide. Any questions on that? All right, so if you're here, you probably know about who we are, but we are collaborative. Many, not just the ones on this call, but the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. I do need my cup of tea. I'm getting a little sleepy, so my apologies. Next slide. You just heard talking about members. So these are the members that make Gravity go. We're incredibly grateful for them. We have some new members, which is fantastic. And we have members leading the work streams that we just mentioned before. Like our implementation work stream has a lot of member-led engagement. Next slide. We are here, and this is our calendar, right? So we've mentioned this every single meeting. On the 30th of April, we have this meeting and one more meeting, an N10 review. And then in a month is when we have our consensus vote, right? So end-to-end review, we'll go back into, we'll talk more again about what the details of end-to-end review are and how we conduct ourselves in end-to-end review. But we are right in the middle of that process and have one more meeting after this one to finish that end-to-end review before the vote. Next slide. A master list. So what we do here in the public meeting is we talk about changes to an artifact And that artifact is what the primary deliverable at the end of our time is. And that artifact is called the master list. It's the list of all the things that, all the codes that exist and all the concepts that need to be created to address a specific domain across our 4 activities: instruments, diagnoses, goals, and interventions. In our meetings, we discuss new findings or, like opportunities or changes to the master list, but the master list is always posted the Tuesday after the call, right? So subject matter experts create ideas, we vet them with you all in open consensus. You all engage in that and help shape it, and then the master list is posted on Tuesdays at 5 p.m. Pacific time at the end of the business day on the Pacific in California, Lucy. And so we do hope you download it. There is no way to encapsulate the breadth of what we all have done together over the course of the last months without looking at the master list. The slides are not sufficient. It is a fraction of what we've done, and that's by requirement because there's too much to cover. So please do download those master lists that are expertly curated by Asha and Sarah Bahal. Sarah Bahal being the hero of that work. And then so that's what we need to review when it comes to end-to-end review, and that's what we're voting on in a month. And again, you can find it on the Confluence under Social Risk Domain Build at the Confluence page of the domain of reference. Any questions on that? Super important that we know where to go. And this, I just want to say one more thing. You can download the master list and share it among your community too, right? So it should be fairly straightforward. Even, we're happy to help the layperson, but we do want to make sure that it's robust and fit for purpose.
Yeah, and one more thing, Sarah, is for those that are, this is the first time through a domain, as with each release, the master lists are updated. So you'll want to download the latest when we do a release.
Oh, so this is not the value set, the release of the SNOMED, which you, um,
With
Susan,
each release, we also update the master file with the codes that have been created.
oh yes, but
Yes.
they are not here. Right. So this is the master list for the vote. So I just want to make sure that you are
Oh, for
correct.
the vote. Oh,
Yeah.
sorry.
No, it's yeah. So I just want to be careful. Yeah. So the master list is on the Confluence page is frozen in time. It is the artifact that you all help create. And then everything that happens after the fact is kind of like submission magic, and Susan, the queen of submissions, is coming in on that. But for the purposes of voting, after every meeting it's updated, and please download it the Tuesday after the meeting. All right. Next slide. Okay, so end-to-end review is a formal, very change control driven process, right? So we've worked together for months. We've all been, tossing around these concepts, reviewing them from different angles for some time. And so what we need to do during end-to-end review is sit back and look at the whole and ask questions, right? So again, download that master Tuesday after the call, ask if something's missing, if something's incorrect, or something needs to be changed. I mean, sorry, incorrect needs to be changed or something needs to be removed. My apologies. And even though we have these meetings in public, we really need you all to submit emails if you feel like something needs to be a change, because we try to just do all responses super formally. So you send comments to gravityproject@hl7.org, and you need to include a rationale and evidence for the alternate approach. I mentioned ANSI accreditation earlier, and Rob, you and I were talking about this before, but yeah, when it comes to consensus, part of the magic of it and requirements of it is really carefully weighing the work we've done together to date. And so throwing a bomb at the end is, without giving a rationale evidence, it doesn't respect that process. So really clear rationales and evidence for why things need to be edited is the name of the game according to our consensus principles. And then everything that you submit in email is reviewed by the subject matter experts and then brought back to the group, and hopefully in time to be edited into the final deliverable at the end of May. Any questions? All right. Okay. I think, well, I see a slide here. Question. Oh, that was just Sarah sending the email. Okay. Next slide. Okay. I'm assuming no more questions. All right. So now we're going on to mistreatment of non-elder vulnerable adults. Again, each of these, Asha and Sarah and I can attest, I think collectively, that these are more stable domains than are usual at this time. To be a month out from the vote and have just fine tuning be the name of the game, which is where we are at with our subject matter experts, is unusual. And so that transfers to you all with there's just not a ton of new content. There's changes to content. Um, when our subject matter experts themselves are reviewing concepts and realizing things can be removed or edited or like adjusted in some way. But there's not a lot of new things. So I hope it's not too redundant based on what we did a couple weeks ago. Next slide. We were just with them this morning, these amazing people. But again, just for another month, I get to thank, well, another month publicly, and then for the rest of time, thank Dr. Jeffrey Hall, Dr. Rana Sierno, and Dr. Shannon Griffin Blake for their amazing expertise. They deeply thoughtful and ethical conversations that we have every Thursday morning to guide this domain. Next slide. So there's a couple tweaks. Remember, so end-to-end review is a time of looking back and seeing whether we need to make edits. And this, Rob, this is me like if you're still on the call, I think you are still on the call. A month ago, maybe, did he get off? Yeah, he's right there. I see you, Rob. Okay.
No,
So,
I'm here.
hi, friend. Okay. So, a month ago, you correctly noted that there was a variable, that there were two different variables in our mistreatment of non-elder vulnerable adults concept, the concept of mistreatment and the concept of vulnerability, right? So, and we thought a lot about assisting clinicians in utilizing the wisdom of our subject matter experts. And so, we unpacked as best we could what vulnerability meant for the purposes of this domain into its own concept some time ago, and we have some edits. So we have the general category of the domain, which is mistreatment of non-elder vulnerable adults. But because vulnerability is only significant for this domain in relationship to the mistreatment, we're also working on this concept for adult with mistreatment relevant vulnerability and we're trying to make sure we wordsmith it correctly. But it relates to there are concepts related to vulnerability and terminology at this time. And there's no concept related to this area yet. So we're trying to lean into it with our definition. Lucy?
Yeah, thank you for explaining what this adult with mistreatment relevant vulnerability is about. And I would like to recommend, my blue pencil in hand, that you put a dash or a hyphen between mistreatment and
I hear you.
relevant.
Yeah,
Okay, so adult with mistreatment relevant vulnerability, as though there's other kinds of vulnerabilities that we can be talking about
correct.
till the cows come home. Thank you.
Love it. Thank you, Lucy. Yes, I hear what you're saying. Any other thoughts or questions? Okay. This is not new. It was presented, I think, a couple weeks ago, but we're just kind of wordsmithing. If you have any other formal comments, please submit them by email. Next slide.
Sarah, this really shows the relevance and importance of having direct patient care practitioners in
Yeah,
these meetings,
yeah.
because they come to all of this stratospheric discussion about concepts with very concrete and tangible needs, which you then
Sometimes,
try to incorporate into the stratospheric concept. So thank you, Rob McClure, for being such a loyal participant here.
and Rob's both. Rob is both a stratospheric terminologist and a clinician. We're talking about you in third person, Rob. All right. Yeah, it's wonderful. And sometimes we're too close to it, Lucy. So it really takes people coming in with really practical needs. And I want to just note the next slide is for that purpose as well. So next slide. So we really tried to think about like how there's no, again, we recognize there's not enough instruments. There's only one instrument in this domain. It's not even specifically for this domain. And we recognize the need to support end users and implementation. And so for the first time, we're kind of talking about what a clinical decision support rubric would look like. And we presented this again for the first time at our last meeting, and there's this kind of flow, right? You establish the presence of a mistreatment, and this is common practice in clinical medicine and in healthcare, where you see someone who has been, like emotionally or psychologically mistreated, physically mistreated, or sexually mistreated, and that is apparent to you. And so, for the purpose of this domain, the next step is to establish the presence of some type of impairment. We had a long conversation about impairment and impairment subtypes this morning. We're actually going to be creating like the example types. They should come back to you by the next meeting. And again, these are not going to be encoded. This is not like an ensuing terminology type. This is just a rubric to try to get the complexity of what our subject matter experts know into a possible practice. And we are committed to developing white papers at the end of each of our domain efforts to try to better capture the subject matter expertise. And implementation considerations is the final step of that kind of white paper. And this would be there. Right, so once you establish the presence of the impairment, the next question relevant to the domain is whether the mistreatment leverages the impairment by making the person less able to independently meet their needs, seek help, protect themselves, or access individuals or social support systems willing and able to provide adequate protection. Again, those A, B, C, and D are all part of the definition, but this is the way the logic would flow. And then you get to that final, oh, so this is mistreatment of non-elder vulnerable adults, right? So I went through this little rubric. I'm here at the bottom, and now I can safely state that this phenomena, this domain is present. Again, this is not new. It's not going to be encoded unless it gets further validated in some psychometric study and becomes something more standardized. But we did create it because of the complexity of this domain. Next slide. So these are the statements of the mistreatment types. Again, these have been stable across a couple different domains. We have physical, sexual, and psychological here. And then you can go to the next slide. Then we have financial and neglect, right? These have been stable for a couple meetings. I'm not going to reiterate them, but these again are those core types of mistreatment that are relevant for the domain that we are addressing. And I'm going to note they are not the same level of granularity that we're going to see in child maltreatment, and that is by intention. Next slide. Oh, Rob, hi.
Hey, I'm sorry, I kind of got lost with the separation of mistreatment and impairment.
Okay.
Can you just quickly run back to that one slide there?
Yeah.
So, is the idea that there's a separate kind of existing impairment, or that mistreatment creates impairment?
There's a separate pre-existing impairment. It's not that the person, and I hear you, that's an important observation. I don't think it's clear in the rubric. So it's not that the abuse broke the person's leg and they have a physical impairment. It's that the abuse leveraged the existing hemiplegia, and therefore the person is at risk.
But so it's not a requirement of mistreatment that there be an existing impairment.
It's not, but it is a requirement of this domain that there be one. That's the vulnerability in the vulnerable adult statement.
Ah, that's how you're bringing in the vulnerability.
Yes.
So why did you not use the word vulnerability then? Instead, you used the word impairment.
That was by request and intention with our subject matter experts, because vulnerable, they think, is the final assessment of the combination of everything we've originally started with vulnerability, and when we get to the different types of impairment, I think it'll make sense. The examples are coming, but it was by,
Okay.
yeah.
I'm not sold, but
You're
I'll
not
let you
you're not
go.
sold on that this should be impairment rather
Well,
than vulnerability?
no, well, I'm asking that. I'm not sure that I would suggest that, but I'm just I'm trying to watch all the pieces kind of come together. And
Mhm.
the the idea that someone is vulnerable, has a vulnerability, let's put it that way. You know, I'm glad that we've kind of teased that apart. I get that this particular domain is mistreatment in vulnerable adults. That,
Mhm.
okay, and that wasn't necessarily clear to me before. I saw them as, that's why I said they're really kind of, they're interacting but independent things. So the then I so now I'm hearing that the way that you guys have kind of big laid it out, the rubric, is that a I'm going to say something that actually you did, that you specifically said is not the way we're thinking about it, but I would think of a vulnerability, that someone who has a vulnerability, that vulnerability you could say, uh, for reasons that I'm still a little unclear on, results in an impairment. Um, I I'm not sure how you separate those two things out, but I'm sensing that's not what you're saying. You're saying that that vulnerability is a bigger thing. It's kind of a final assessment that someone is vulnerable, and that is based upon impairments. Is I don't want to
Yeah,
augur in.
no, you're okay. You're right there. So
Okay,
yeah, so simply
you're
vulnerability is
vulnerable
a relate,
because
yeah,
you have
vulnerability is, yeah, sorry.
this thing, this problem, and that makes you vulnerable. And
To
or
what though?
that,
So this is like,
well, right. I mean, but you know, it's, I don't want to fall down that hole of saying that it's a problem, because, for example, people have problems. People have an issue with, calling pregnancy a problem or something like that. So there are situations that lead to vulnerability that aren't seen as negatives by the individuals who are, let's say, experiencing them. They're just there. Others
I think
who
you're
are
putting,
sophisticated may utilize that situation, and exploit it as a vulnerability. So anyway, I don't, like I said, I don't want to spend a bunch of time on that, but none of those things lead necessarily to mistreatment until an event occurs where that vulnerability is exploited. So I think okay. Anyway, I'm just expounding, but I just wanted to make sure I understood this, that does mistreatment leverage the vulnerability? And and yes, but
well,
then there
careful. We're
wasn't
not, I want to be
vulnerability.
careful. We're not saying, I don't want you to replace vulnerability with impairment.
But you did, because you said the question was, does the mistreatment leverage the vulnerability? But then you don't ask about vulnerability.
Oh,
You
sorry. I'm sorry.
establish
Whether the
presence
mistreatment
of
leverages the
impairment.
impairment is what it says, not the
No, it
vulnerability.
says, does the mistreatment leverage the vulnerability? That's the question right there on the slide.
At the time. Oh, okay, there we go. The top question. I hear what you're saying.
Yeah. And
Okay,
then it doesn't say vulnerability.
I
It
hear you. No,
says,
I should have taken that sentence off. My apologies. I hear right that. Okay,
okay,
my apologies.
that helps a little bit. Not totally, but all right. Now I'll be quiet.
Well, okay, so I should have taken the primary. Okay, I should have taken that sentence off. My apologies, because the what the questions you're asking are very much the questions that we thought about this morning, right? So vulnerability is a relational statement. Vulnerable to what, right? And so that necessarily involves some kind of like interchange, right? It's not just you're not just lying there being
Right.
vulnerable. You're vulnerable.
Vulnerability is a two-way, two
Is
entity thing.
Yeah, yeah. So vulnerability is intended to be the final statement, and it's intended to be the final statement based on a couple things. Impairment, and we'll come back with this, are some kind of finding that limits function, usually, right? Whether it be, a
Yeah.
cognitive function, whether it be psychological function, whether it be a physical function, right? And we were talking about that in ICF this morning, right? And so this domain, the reason why you would trigger a report to APS, which is the end statement of this, why you
Mhm.
would override someone's autonomy, right?
Mhm.
It's because in this instance, this person is at such significant risk because the mistreatment's leveraging the existing impairment, right? Like it's that relationship, right? And that establishes this vulnerability for the purposes of the domain. And there's socioeconomic vulnerability. There's like age vulnerability. Children are vulnerable just by age, right?
Okay. So
Yeah.
sorry. I'm gonna say one more thing and then I'm just gonna shut up. So I
Okay.
don't, I don't, I don't necessarily agree with the way you just characterize things. I'm sorry. So one of the things that I'll just say, because it's not really germane to this particular conversation, is just it reminds me that vulnerabilities don't require an additional person. Like you could be vulnerable for to falls, right?
Okay, I hear
And
what you're
you can
saying.
have a fall and you're vulnerable for that
Well, there's
because
some
you're
kind of,
dizzy.
but there's some
That
kind of like there is a vector, there is a
no,
there's something happening there. You're vulnerable
so
to
yeah,
something.
yes,
Yeah.
yes. But just so that we understand, vulnerability, the idea of vulnerability doesn't require two individuals or two, it requires an impairment, I think, probably, and an event, right? Like
Correct.
you're dizzy, that's your impairment, and you're old and you get out of bed and you fall. And people know that because you have a tendency to be dizzy, so they know you're vulnerable for falls. We talk about it that way,
Okay.
and
Yeah,
we
that makes
record it.
sense.
So
Yeah.
so that doesn't require that someone came and pushed you, right? So that I just wanted to say that with regards to vulnerabilities.
Okay.
And then the the thing that you guys have established, and I don't want to break that, but it's a weirdness in terms of the way I think about things. I would think about the fact that if you have an impairment that makes you vulnerable, it does establish the fact, and then I would think of mistreatment, leveraging that, certainly, but the leveraging by an entity, let's say, of a vulnerability, of an impairment, resulting in mistreatment is the way I would think about it. I don't think about things like the fact that there's an impairment, i.e. a vulnerability, and then there's a mistreatment that leads to, I don't, vulnerability already happened. I don't think about that leading to vulnerability. So it just, it just sounds a little backwards to me. I don't want to break your
I don't think
train
we
of
disagree in
processing.
the final assessment though. So, right, so like there's a mistreatment, right? There's an episode of mistreatment.
Yes.
There is a
I
impairment.
believe
Yeah.
everything that you got in here, other than, you know, I'm okay with. The idea that vulnerability is represented as impairments, I guess I'm okay with that too. The last point of equals mistreatment of non-elder vulnerable adults also makes sense to me. That vulnerable adults piece, I think I would have just said establish a presence of vulnerability, but there's something else you're going in there. I think you're saying that there's more nuanced distinctions that are impairments that lead to this general idea like you're vulnerable, right? So you may have more than one impairment that makes you a vulnerable adult, or you may have only one impairment that makes you a vulnerable adult.
Or the
None of
impairment
those
might
are
not match the impairment might not match the mistreatment. Like if you are physically if you have a physical impairment, but you're getting emotionally abused,
Yeah,
right? So this
or
all, yeah,
financially,
yeah,
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 totally.
yeah.
That's why I said they're really separate. So I'm glad that that's gotten clear.
Okay.
So all that's okay. I just wanted you to come back here 'cause I got lost because I was like, "Where's the vulnerable part?"
Okay,
Okay,
so we'll take off the first sentence, and I think violent agreement, Rob. I think so. I will
that was
have
a
this.
hair flip on my part. Yeah.
I know, I'm joking. So I will have the SMEs come back, Nick, because unfortunately they're not here today, and talk further about why we're not using the word vulnerable and using the word impairment because they feel very strongly about that, and I'm not able to represent that well for them. But I think regardless, the general principles here are sound, is what you're saying to me, and we'll lead.
Yes,
Okay.
I think so. Yes.
Okay, great. Lucy? Sorry, that was a lot of Rob and Sarah back and forth, but it was good. It was necessary. Send in review. Lucy?
When I hear Rob speaking, it all sounds very logical to me. And I'm wondering if it would help anyone except me to have three overlapping circles: vulnerable, impairment, mistreatment. And then you point with an arrow to the overlap that this concept applies to, because it clearly there are elements of vulnerability, impairment, and mistreatment that have to be shared for this conceptual purpose, but there are also elements that may not be shared, but they exist. So if we had three overlapping
I
circles,
don't think it would be an
no,
overlapping circle, though. Maybe not. You mean like a Venn diagram? You mean like a hmm. Oh, okay. Do you mean like a
one circle is vulnerability, one circle is mistreatment, and one circle is impairment. And how those concepts and realities relate is what we're struggling with and have been, and that our SMEs feel very strongly about. And I'm just wondering where these three circles overlap, that's what we're dealing with here. But we're not dealing with everything that happens in the realms of vulnerabilities, mistreatments, and impairments. At least that's how it seems to me now.
we're certainly not dealing with everything regarding to vulnerability. We know that because there's many types of vulnerability that are not within this domain. I will see what I can. I'm going to bring back the SMEs in a couple weeks, but regardless, the rough basis is true. I will have them detail why we didn't use the word vulnerability instead chose impairment because I'm clearly not able to do that well. I started with vulnerability there, and it was intentionally changed. So I'm going to try to have them come back and detail why that's the case for all of us in a couple weeks.
Thank you.
Okay, sounds good. Okay. Keeping me on my toes. That's what
I mean,
I,
it's so obvious to me that mistreatment creates vulnerability, that there can be vulnerabilities that are exacerbated by mistreatment. I mean, I'm just that's seems obvious to me, but clinically that may not be the logic that's going on here. Okay, enough.
I just want to note that there's a little bit of disability justice stuff going on here too that I'm not able to put my finger on well. Because not all impairments are seen as vulnerabilities within that lens. And I wish Shannon was here to help us detail that, but I know I'm not detailing that well, right? Um, and so I'm going to have them come back on does that make
That's
sense?
definitely true, Sarah. I mean, the whole disability rights movement, um, if you're not in it, if you don't have the disability that they're talking about and you're observing and being sympathetic, you can acknowledge that they don't want to be seen as vulnerable
Well,
just
yeah,
because they have this impairment.
yeah. I'm just I want us to sit in the fact that the dual the assumption of equivalencies there, not that this was being done, but that was part of why we undid vulnerability and put impairment in there. was from that perspective, right? Because the
Mhm.
impairment, right,
Mhm.
plus the maltreatment type, right, is what creates the problem, right?
Yeah, I'm
And
gonna say one thing. Unfortunately, I'm gonna probably have to leave. I got an overlapping meeting, but but
oh my God, it's
without having any of these things, this is very a stretch for me. But that's why I would have thought vulnerability would be a better name. Impairment definitely sounds like there's a problem. Vulnerabilities, we all have vulnerabilities. So, um, anyway, but
We'll
obviously
come
your
back.
SMEs feel very differently about that, which is surprising to me. They feel like impairments are, I don't know. Anyway, I just think of vulnerabilities as being something that just is a common thing that and is a representation of um, anyway.
Humanity.
Yeah.
I know. But yeah, okay. So our Billion Speaks, we will meet with them next week. I will try to tell them how awkwardly I tried to represent their brilliance. But the real question is why the word is impairment and not vulnerability in that rubric, correct? And then and we will have them come back in 2 weeks and help us understand that. It's easy enough to replace if it's non-essential, but I will lean on the wisdom of those SMEs to help us get there. Okay, here we go. Go team. Next slide. There's no new instruments here, so hopefully we can move through. This instrument's been on there for some time. Please go to the master file on Tuesday and look, and you can find it there. There's actually not a ton of new interventions either. There's some changes to interventions. So if we go to the next slide, we um, we have gotten a crash course in the programs that support adults with disabilities by federal regulation across the country. And this is a huge, and the programs that we connect individuals to. And so these updates are related to that. So independent living, again, I'm only going to focus on things that have changed. We had independent living programs on here, and that was what we presented 2 weeks ago, but we are not meaning all independent living programs. Like I have independent living programs in my community that focus on the needs of older adults in lovely intentional communities that are, built for that purpose. What was intended by this are the capital I, capital L, capital P independent living programs that are funded through the Administration of Community Living to support adults with disabilities and living independently. Those are all guided and administered in states by Centers for Independent Living. And so, where I would refer a patient to or a client to is the Center for Independent Living for that region. And that Center for Independent Living does an amazing array of things. They do intervention and referral, they do peer counseling, they do case management, they do like education of family and individuals. So those centers for independent living are the core program to differentiate them from other types of independent living. And so it's now Center for Independent Living. So I'm referring to the Center for Independent Living and educating about it. And that is where I direct patients and clients to, and it's where I direct them to now in my own practice, the State Center for Independent Living. Lucy?
We're all learning a lot here, Sarah. Is it possible to imagine another column in this matrix that says source, like forensic accounting, source,
You mean like
multiple private practitioners, or Center for Independent Living, federally funded
oh, the
state
definitions, the
thing?
definitions do that 100%. I promise.
Okay,
Yes. And
somewhere. All right.
well, no, they will be definitely every single one of those TBDs will have a definition by the time we vote. So I almost put the Center for Independent Living in definition in now, but suffice to say, every concept needs a definition, and every definition has to have a reference. And that's all part of our work, 100%.
Oh, well, it was certainly news to me about Center for Independent Living being a federal program.
Oh,
Whatever
yeah.
they do, it was just news. So
I know. Well,
to be in here somewhere. Thank you.
I love it. Another thing that's changed in relation to that is we had developmental disability services, but really, when you think about where you're sending people to, it is the Aging and Disability Resource Centers, or the ADRCs, which are again federally legislated and federally supported. And so developmental disability services was redundant once you have the Center for Independent Living and the agency and the Aging and Disability Resource Center. So that is now crossed out because it's non-specific and redundant. It might be applicable in non-US settings. But for the US, the way it's operationalized is ARDCs and CILs.
Are you
Go.
saying that the ADRC treats children with developmental disability as well as old people that have aging problems?
They are the place you send people to. Yeah. But of course, that's
Interesting.
some of that's covered under Medicaid. So some it's a little bit tricky with PD because there's additional services that are come through, but ADRC is the primary source of reference for disability services regionally. Yeah.
That's interesting because pediatrics tried for decades to get their own emergency rooms. They didn't want to be with other people. So suddenly I'm learning that these resource centers treat everyone who walks in the door regardless of age. Okay, thank you.
Okay. All right. Do these updates make sense? Okay. Again, this is classic end-to-end review business. Next slide. And I don't think there's anything new here. These are all just things that have been there for some time. And you can all find them on the master. And all of these have definitions and codes and things, or at least most of them do, because they came from prior domains. Next slide. This is unchanged. This is the CUES model that was critical for pre-screening with maltreatment. Next slide. And next slide. Oh, the goals. These are new. We brought in all but the last goal, and the last goal might need to be terminology finessed a little bit. Come from our domain of elder abuse and intimate partner violence, our past work in interpersonal safety. Feeling safe, adequate social connection, receiving as much social support as wanted, limiting perpetrator access to victim, and enhanced social monitoring. There was a desire to represent, the maintenance of autonomy, especially with disabled adults, while reducing risk, and we're finessing that from a terminology perspective. But that's the only new concept that wasn't in a prior domain. All right, next slide. Any questions on mistreatment of non-elder vulnerable adults? We had a huge conversation on concepts with and we'll have our SMEs back in 2 weeks to talk further about differences between impairments and vulnerabilities. And I should say, Rob, there's a gorgeous vulnerability matrix that one of our SMEs has made that has all types of different vulnerabilities, and we envision the vulnerability section in SNOMED to have all kinds of opportunities for enhancement. Any other questions before we go on? All right, next slide. On to child maltreatment. Next slide. So these amazing subject matter experts, these three are Dr. Emily Brown, Dr. Catherine Wells, and Dr. Phil Scribano. Emily's on the call today. At least she was. Hi, Emily. These are amazing child abuse pediatricians who have been working extensively with us over the last extensive time, and we're just incredibly grateful for them. And this domain has some winnowing as well. So end-to-end review is a time when we sit back and look and don't just add things. We sometimes remove them, and there's some winnowing that we've done as well. Next slide. This definition is unchanged. Next slide. And next slide. This is where there's some changes. So originally, when we looked at instruments, we included instruments that had questions that address child maltreatment, and the Pearls questions have questions that address child maltreatment. But the global instrument is not was not validated for that purpose. You'll remember it from our ACEs domain. And so there are many questions on that instrument that do not relate to our domain. And there is no subsection on those instruments to pull out the maltreatment relevant questions. So when we sat back with our end-to-end review and we said, is this instrument really holistically, as it stands, an instrument for screening for child maltreatment? The answer is no, it was not designed for that purpose. And two, it would be difficult to include in our sets because there's many questions that are not relevant for our domain. So for now, the SMEs stepped back and they decided to pull them from the set given the lack of complete alignment. So I think, oh, well, so Lucy, you actually asked us to examine that earlier, and I think, I don't know if Emily wants to respond to that, but the date that we are not expanding the age to 21 for this domain. I think you brilliantly asked that question earlier on in the work. I don't know if Emily wants to come on and answer that. But okay, I think maybe Emily's having a hard time with that. But regardless, the questions on instruments, does that make sense? So we removed instruments that had questions that were not relevant, but everything else is here.
Sorry, I'm here now.
Hi, buddy. So Lucy asked a question about ages and why we didn't go up to 21.
I don't know that we ever really explicitly discussed it when it comes to questions of autonomy and kind of reporting process. 18 is a very fine line in the child maltreatment space. And so I don't know, I'm not seeing huge advantages to switching it 21.
Thank you, Emily. Lucy, does that
We
answer?
can
Okay.
discuss.
Yeah, they can further discuss it. Well, the
Okay,
word
there's so
child,
there's so much pressure, at least in my limited experience, to reducing the age at which children can be prosecuted as adults for serious crimes. So I'm just thinking about the opposite. Should we be extending protection for, quote, children, unquote, to a higher level as a kind of counter to that? So that's way too abstract for our task here. Thank you.
but also upends the definition of what it means to be a child, Lucy, right? So conceptually that the expansion makes sense, but even though foster care and many things extend, pediatric insurance coverage, right?
And
Definitions.
ACA coverage goes to 26.
Exactly. Yeah. Yeah.
Okay.
Yeah. Okay. I think we'll bring it to the SMEs, but I do think we actually discussed it way, way early. And so we'll revisit with them. Okay. But do the instrument changes here make sense? I hope so. Fairly straightforward about why we removed the 3. Okay. Next slide. Next slide. The significant change here is that even though we had children in the definitions, we didn't have child in the concept, and all of the existing terminology actually already has it, so we just needed to put it in there, right? So child physical abuse, child sexual abuse, child psychological abuse, and medical child abuse. It was actually already in child. So we hadn't carried through that concept into in the child concept into the concept itself. But it was in the definition, every single one, and our existing terminology supports that as well, is what I'm trying to say. Any questions here? All right, next slide. Same thing here. These are different types of neglect, and I mentioned this earlier, but there's different levels of granularity, right? So we have one neglect concept for the mistreatment of non-elder vulnerable adults, but we have 4 in pediatrics. really because of the responsibility relationship there. And there were some really clear, there's some very clear opinions on aligning with existing elder abuse approaches in the abuse of non-elder vulnerable adults work as well. But we have these four concepts here in the child maltreatment domain. Next slide. Next slide. These are stable. We have the culture connectedness concepts were part of our protective factors work and our ACEs work, and so they are getting submitted to SNOMED at this time. We already have definitions for those. Feeling safe is a constant. We saw that in our prior domain. And then exploring, of course, pediatricians would aim for healthy social and emotional development. We might have to have those as two different concepts, well-being and realizing potential. Those are all, wouldn't be a pediatrician unless you cared about those things. Next slide. Again, this is constant from last time. Yes, they do cover so much of life. I also wish that my older patients, my adults, have well-being. Correct. Next slide. Next slide. I'm just going to go because this is not new. These are so stable. I'm just going to move through them. Next slide. These are all very stable. Next slide. And next slide. We have not changed these in a long time. And these are ones that we have had from prior domains that we pulled in. Next slide. And next slide. Okay, so that was child maltreatment. The biggest changes are in the removal of a few instruments because they were not specific to the domain of reference and they were questions that were not aligned with the domain, and the addition of child within our primary concepts. We already had it in the definition, we just didn't pull it into the concept itself. Any questions there? All right, on to legal needs. Thanks, Rob, you're so patient. Next slide. All right, now to our legal needs SMEs. Jeremy Spiegel, Marcia Regenstein, Omar Martinez, and Teresa Brabson. So grateful for these amazing folks. They are all, but one of them, attorney, trained, have Juris Doctorates and help us with their legal and ethical advice on the regular basis. Next slide. Next slide. No changes here. So we have iHelp and we have the OPAL instrument. These have been stable and you can see them on the master lists. Next slide. And next slide. These are also stable. The format's different this time because the amazing Sarah Bahal moved it into the table format. We had them on a slide, but these are the concepts and their aligned definitions. Next slide. And next slide. Definitions TBD, again, Lucy, just like the others, all those we hope to have those TBDs filled by the next time we come back to a meeting in 2 weeks. So you all can review the definitions prior to the consensus vote. These should be fairly easy to define. Next slide. Because there's lots of international definitions for what legal advocacy looks like, so fairly straightforward. Next slide. Again, this is very stable. We had the patient navigation concept. This is already an existing SNOMED CT code. And then we have the patient navigator and intake specialist concept. Next slide. And then you can see some similar concepts from the child maltreatment, in the prior domain. So we have psychologist, housing navigation program, family strengthening program, parent support program, health insurance navigator program, and victim advocate program. So some of these are all from past domains and already have definitions, and you can find them on the master. Next slide. Oh my gosh, is that it? Wow. Amneva took a bit, and then now we're just racing through. I think there's only one more thing because we moved the specialty concept off of here to focus it in the service classification work that we're doing. Okay, Any questions on legal needs?
Sarah, this is going to sound really off the wall,
What?
but if a child has, and forgive my language if it's not as up to date as it should be, if a child has an intellectual disability and a local school system is legally obligated to provide education for them within the existing system,
Yeah.
do healthcare clinicians ever get involved with that, where the system is either resisting or it's not
All the
doing what it should
time.
be doing? So should that be on the list? If you go back a slide,
Oh, you mean like like
yeah, here, should that be education strengthening or I don't know, something about um, getting school systems to respond to something.
that's an interesting thing. So the first answer is yes. Pediatricians and family practice clinicians have care team meetings with school-based providers all day, every day. Not all day, every day, but often. Um, and we're regularly called in for IEP review meetings and 504 plan reviews, right? And we often offer testimony, and then we often are brought in to deliver concern when the plan is deviating from recommendations. So all that is true. Whether that fits into I mean, so you're saying that within school negligence, you want to know if that is an intervention for like education neglect. Is that what you're saying? Like, what is your,
Something along like everything that you just described, where in our concepts, which of our concepts would cover what you just described?
if the educational system is the one maltreating the individual, because we did elevate as opposed to the parent. Is that what you're saying? Or caregiver?
Yes.
Okay.
And you just said you testify. So that
Oh
means you're
yeah, I
involved with
do.
lawyers. So you interact with lawyers
Oh
about
no,
what
it's not
kids
with
need.
lawyers. It's with oh, this is legal needs too. It's not just child maltreatment. I'm sorry. I'm getting a little okay. I hear what you're saying. Okay,
Okay,
so
just think about it. We don't have to solve this here. I'm
no,
just
no, because we talked
raising it.
about child. No. I hear what you're saying. We actually had an educational advocacy concept that and we felt like it was so wrapped into the non-attorney legal advocacy concept that we removed it. Because of the child use case, my brain went back to child maltreatment, but we're in legal needs, right? So, I actually feel like that makes sense to me because if for a legal needs intervention, Lucy, because it's like not all legal needs involve meeting with attorneys. Our SMEs have been very clear about this. And failure to comply to a 504 or accommodation plan
Mhm.
is and the interventions that clinicians and social workers and care teams do toward that end, we will bring that to our legal needs SMEs on Tuesday. I
Okay,
got it.
great. Thanks.
Okay. Whew. I got there. Okay. All right. Okay. Next slide. We only have one more thing, and that's the lovely patient experience of social care measure, which is unchanged. This is this long-awaited assessment of patient experience and satisfaction with addressing social needs in clinical settings. And we're super grateful Siren developed it, and we are really honored to host it here. As I mentioned, we've been talking about specialties in this meeting, but I'm going to be moving the specialty conversation to the open meetings that where we're talking about the service type classification and social and the service code eligibility work, because actually the specialty concepts are meant to pair with service types. So we're going to move it over there, and we're not in a rush. And so I think it's appropriate to move it over there. It won't be part of the consensus vote here. It's just going to take some time. Next slide. And we're good. Next slide. Oh, these little sweeties. I'm sorry. Can't forget these little adorable codes. Assessment social care needs, referral to patient navigation service, referral to community health worker, referral to medical legal partnership program, and education about medical legal partnership program. So we are adding a synonym to referral to community health worker that already exists to encompass the concept of promotores, which is widely used as a synonym for community health worker. And then we need to add a hyphen to the referral to medical legal partnership. Lucy, this is like the blue pen. Because our SME is adequately represented, that medical legal partnership should be hyphenated. It's not currently hyphenated, so we have to edit it there accordingly. All right. Next slide. Okay, I think we're good. Homework. Next slide. Our homework is very clear. Thank you all for coming. Thanks for putting up with my slightly sleepy brain as I tried to wrestle with big conceptual questions. And we did that well together. Your primary homework is downloading the masters on Tuesday, reviewing them, sending in emails with rationales and evidence if you feel like something needs to be changed, removed, or added. We will bring the few things here that are not end-to-end reviewing over to the SMEs. Even the impairment and vulnerability conversation, that was within the rubric, which is not a formal part of our deliverables, but we'll still bring it back in 2 weeks. And then we will see you in 2 weeks' time, which is our final end-to-end review meeting before the vote at the end of May. Any other questions, Super Friends? Thank you so much. It's been a pleasure. And we will see you in 2 weeks. And again, feel free to write with any questions. And please do come to the technical call on the 13th to talk about the conceptual model if you'd like to.
Sarah, I just want to say how lucky we all are to have a real philosopher guiding these meetings.
Yeah.
Yes.
Wow, that's very sweet. I'm sure my philosophy professors in undergrad would love to hear you say that about me.
Yeah, you tell them their influence has had a very, very long-term effect.
Okay. Thank you.
Okay,
Bye.
bye.